Good morning. My name's Corey Hansen, and today we're going to talk a little bit about policy analysis and then actually analyze a policy from the North Carolina House of Representatives 2017 session. So first of all, in general, just when you're analyzing a policy, you have to consider multiple things. You have to consider cost, ethics, autonomy, vulnerable populations, and then we have to consider how we're going to make sure that policies include equity and fairness for all people. So first of all, when you're looking at costs, it's a major factor in health policy, and some policymakers do not see the benefit of putting more money into health policy rather than just cutting costs there. So a way to kind of combat that is look at, could we raise taxes a little bit, or can we allocate funds differently in the healthcare spending budget to allow for greater access to healthcare? These are just a few things to consider. And then ethics are also important when analyzing policy. So when you're looking at a policy, you're considering more than just the individual, but you're looking at groups, communities, and the entire population. So you have to determine the long-term impact on these, not just the short-term benefits. So question lawmakers might face are, what is good or right, and how do we justify what we've defined as good or right? And then autonomy is another major factor. So with you and I, we might say we have autonomy, but when you're working with a community, how does a community have autonomy as a whole? Is that possible within this policy? If not, can we make it that way and give everybody the same benefit and the same freedom? And lastly, we have to ensure that policies include equity and fairness for all people. Do they protect vulnerable populations? How do we combat that? What can we put in place to ensure that a policy does not cause one population to be more superior than the other? So these are just some things we have to consider. All right, so now let's talk about North Carolina House Bill 789 from the 2017 session, the End of Life Options Act. It's described in the act in the longer title as an act establishing an end-of-life option to allow qualified patients diagnosed with a terminal illness to end life in a humane and dignified manner. So I'm going to spend a few minutes just kind of summarizing the policy itself. So the End-of-Life Option Act allows individuals diagnosed with a terminal disease to end their own life at home on his or her own time. The bill grants the physician the ability to write a prescription for a drug that, when ingested, will cause death. So there's a couple, as you can imagine, stipulations for this act. So the patient must have the ability to make his or her own decisions. Nobody can decide to enact this for the patient. It's the patient's own decision. This patient must be diagnosed with a terminal disease. This is defined as an incurable and irreversible disease that will result in death within 6 months. So the person can't just say, hey, I want to take part in the end-of-life options. No, they have to make 2 verbal requests, 15 days apart, followed by a written request. These requests must be signed, dated, and witnessed. So the patient will be evaluated by 2 physicians. If either physician suspects any aspect of mental illness, depression, suicide, etc., then the patient is to be referred to a mental health specialist and will not be granted a prescription for the drug. So how this works is after the patients go through the process and are approved, the physician can then write a prescription for a drug that is a controlled substance, and the patient can pick this up from a pharmacy. There's a bunch of forms that have to be filled out. And then the patient can have this drug in their home. It has to be protected in a locked space. Nobody can have access to it besides the patient and the defined witness, which we will talk about later. And then the patient, whenever they are ready to kind of end their life in a dignified manner, they're allowed to ingest this drug, and death should theoretically occur. So I was talking about the witness. So the patient must declare a witness. This witness must be present when the patient ingests the drug, and the witness is also responsible for filling out a completion form after the patient ingests the drug, and the witness must turn this form into the attending physician within 48 hours of death. So now we'll look at some key stakeholders of this policy, including the patient, the physician, the appointed witness, nurses, and state lawmakers. So in regards to the patient, does the patient really have the right to decide when it's his or her time to die? The policy is presented as death with dignity, but is death really the way to dignity? Patients in the hospital have the right to request more pain medication that can ultimately speed up their death. How is having a patient administer a medication at home different than sedation in the hospital? The biggest driving force for the request of this policy in other states is autonomy. Patients want to control their death. Is that justification for a law? Loss of dignity and inability to do the things that patients enjoy are other driving factors for the request. Patients who request but did not take the medication in Oregon reported better symptom management and more control over the death. It's important to note that the patient does have the right to retract their request for the drug at any time. Next, we'll look at the physician. Physicians are typically trained to save people, not to help end life, so this kind of goes against their moral and ethical values in the way that they were trained. Physicians who partake in this practice speak of a large time and emotional investment. The physician is required to refer the patient to another physician if he or she believes that the practice does not align with his or her moral values. It can become risky for the patient when working with vulnerable populations. What if the physician prescribes a drug to a patient who turned out to be mentally incompetent or mentally ill, and that patient ended up committing suicide? What if the drug that the physician prescribes comes into the hands of the wrong person? We need to figure out ways to protect the physician in this policy. In addition, physicians must be prepared to address other options with patients for end-of-life care. Physicians should be able to address patient strengths, suicide risk, and fears. They must affirm their commitment to the patient and present all available options. Next, the appointed witness comes into play in this policy. A lot of emphasis is placed on the appointed witness. They're required to be with the patient when he or she ingests the medication. Then they're required for the follow-up after ingestion. The appointed witness must fill out the form and submit it to the authorizing physician within 48 hours of patient ingestion. Furthermore, the witness is required to waste this controlled substance. What if the witness fails to return the form? What if the witness does not return the controlled substance? How can we protect the witness from helping their loved one in this situation? Nurses are also inadvertently affected by this policy. As a nurse myself, patients always ask about their options when it comes to end-of-life or terminal illness. And nurses must be educated to respond to patients, allowing them to make informed decisions. Nurses have the responsibility to talk with patients and ensure that everything has been done to relieve their symptoms. Have we offered palliative care? Are we controlling their pain? Do they want to partake in any of the other options currently available? Right now, this policy goes against the Code of Ethics. As it states in the code, nurses cannot act with the intent to end life. So there's some moral and ethical dilemmas that must be sorted out and redefined before this policy can be successful. And then lastly, this policy impacts state lawmakers, as they must decide if this is ethical. They have to look at the population as a whole rather than just an individual and see if it will benefit everybody. How are we going to protect those vulnerable populations? How are we going to protect people who do not have the ability to ingest medications? Will this policy open the door for further issues such as physician-assisted euthanasia or mercy killing? Moving on to the key factors, we'll discuss quality of care, economic factors, and a little bit of legal and social factors. So in regards to quality of care, proponents believe that this bill will allow patients to die with dignity. Oregon residents responded in a survey that simply attaining the drug allowed patients to have better symptom control and be better prepared for death. However, opponents of the legislation believe that the bill opens up a healthcare dilemma for vulnerable populations, such as physically disabled or mentally ill patients, or patients who cannot take anything by mouth. Others believe that quality palliative care and goals of care conversations can allow patients and providers to make informed decisions related to the values and put goals into perspective of the clinical situation. Therefore, more information is needed to determine if this bill will improve the quality of care. Next is the economic factor. So an economic impact, though not the reason for the bill, could be enticing. Before implementing physician aid in dying regulation, authors in Canada performed a study to determine if implementing aid in dying would increase medical cost. Using data from the Netherlands, the analysis realized that only a small percentage of people actually died due to aid in dying drugs. Furthermore, they calculated the price of care of an individual on an individual patient level, using costs associated with death and terminal illness, such as acute care visits, outpatient visits, labs, drugs, and long-term care. After running multiple scenarios, both low and high, the authors came to the conclusion that the adoption of an aid in dying law in Canada would not increase healthcare spending, and it may even decrease spending by tens of millions of dollars. While it is not morally correct to put a price on life, adoption of aid in dying or the End of Life Options Act could inadvertently help reduce healthcare spending. And then the social factors of this bill were addressed with the key stakeholders. But implementing this bill to allow aid in dying would ultimately cause ethical and moral dilemmas for nurses, physicians, patients, and families. The healthcare field must be able to respond to patient inquiries with informed decisions and honest communication. So now we have a couple options related to this bill. We could support the End of Life Options Act and support the ability for patients to obtain a drug to take themselves and ingest when they are physically and mentally ready to pass away. We could do nothing and let policies kind of stand as they exist and continue on with palliative care services. We can suggest a need for more regulation regarding the drug, such as where specifically the drug is supposed to be kept, how can we ensure that nobody else can get their hands on the drug, and include protections for the authorized witness regarding the drug and filling out the forms. Or lastly, we could increase support and the requirement for palliative care services. I personally believe that there are a lot of palliative care resources out there for patients and that they are underutilized. So I would like to see us utilize palliative care, pain management, and sedation better before we jump into enacting a law that has many moral and ethical dilemmas. So after analyzing this legislation that allows for prescribing aid in dying drugs, I recommend to try to increase palliative care and support services for better end-of-life care for patients. Prescribing a lethal drug seems too unsafe at this time. Quality evidence needs to demonstrate that this practice does indeed improve quality of life before legislation should be implemented. In addition, there should be a gatekeeper to protect the appointed witness from psychological, legal, and physical harm. While the idea for the End of Life Option Act seems excellent, it is better to utilize the palliative care resources that we currently have. So this concludes our policy analysis. I'm interested to see what you guys have to say about the topic and what your thoughts are. Thank you.